All right. So what I wanted to do for you guys is just a little bit of looking forward. We're going to go over some practice questions, kind of in more of the PANCE format. This is the physician assistant review book that I a lot of times will plug for you guys. I really like this book. So I just wanted to go through the nephrology and urology questions and the way that I kind of think about those. And what things are high yield for questions and the way that you should be thinking about them. So the first question reads, according to the Rifle classification, risk of kidney failure begins with the reduction of the patient's GFR by more than what percentage? A, 10%, B, 25%, C, 50%, and D, 60%. So the answer here is that the Rifle criteria starts at 25%. So the answer is B, 25%. Expert consensus by the Acute Dialysis Quality Initiative group defined the risks of reduction of GFR by 25% or more, injury, and defined as a reduction of more than 50% is failure, and then a reduction of 75% or more. So let's kind of distill that. So what they're saying is an acute increased risk. That's the first R in the mnemonic Rifle. So risk for kidney problem is going to start for an acute kidney injury or kidney failure is going to be 25%. So that's R. And then injury is 50%. And then as we progress to failure, that's the F, and that's going to be 75%. So that Rifle criteria is going to just keep coming up and coming up and coming up. So just good to know that the risk starts at 25%, and then it's kind of easy to go to the F being 75%, which means failure, and then on from there. Okay, question number 2. A 41-year-old was involved in a motor vehicle accident and sustained a fractured pelvis and a ruptured spleen. Okay, that's bad juju to start there. He underwent surgery and was admitted to the ICU. He required 4 units of blood. The next day, his urine output dropped to 10 cc's per hour. So he's not putting out any urine. We know that we've got some sort of a problem. Okay, plasma expanders did not improve output. Okay, so we gave him some plasma expanders like probably FFP, and that did not improve his flow. So that means it's probably a renal problem, plus we're in renal. So that would make sense. Laboratory findings reveal an elevation in urine sodium excretion. Okay, boom. Sodium is going up in the urine. Now, normally, if someone is low volume status, they should be maintaining their sodium. So we already know that the tubule is damaged. Okay, so laboratory findings reveal an elevation in urine sodium excretion. Ding, 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 there's tubule being involved. BUN is 70 milligrams per deciliter, so that's high. And the serum creatinine is 5.9. That's also high. Urinalysis reveals granular CAS. So we already know we have a tubular problem because we have sodium. Now we really know we have a tubular problem because we have granular CAS. So even before the question is over, I already know that the tubule is going to be something that I'm interested in. So what is your most likely diagnosis? A, acute tubular necrosis. B, bladder outlet obstruction. C, cirrhosis. D, hypovolemia. E, renal artery stenosis. Okay, so just kind of to dissect that, I mean, I think for the majority of you, the answer is staring you in the face, but let's go through these. So not likely renal artery stenosis. This usually is going to come on over time, probably not paired with a lot of this other mumbo jumbo that's in the stem. So we can rule that out. Hypovolemia. Well, this guy probably was hypovolemic at one point. He probably did have an acute kidney injury secondary to hypovolemia from the trauma and the loss of blood. But that's not what's going on now. His volume status has been repleted. So even though that may have triggered the initial kidney injury, we're dealing with a different beast here. C, cirrhosis. No, not likely. Cirrhosis can cause some problems, but not like this. B, bladder outlet obstruction. Well, the labs do suggest a pre-renal. The labs do not suggest pre-renal or post-renal because we have a high urine sodium. If we had a pre-renal or post-renal, we should have low urine sodium. So we know it's a tubular problem. So the answer is A, acute tubular necrosis. Let me give you their thinking here. So acute tubular necrosis is a very common cause of post-operative kidney failure. The laboratory findings confirm an intrinsic cause to the kidney failure. Bladder outlet obstruction would cause a pre-renal acute kidney failure, but no CAS would be seen. Cirrhosis, hypovolemia, and renal artery stenosis may cause pre-renal acute kidney failure, but urine sodium excretion would not be elevated. Okay, so that's their reasoning there. So I think it's very appropriate. Okay, number 3. A 10-year-old boy is brought to the clinic for evaluation of dark urine. The urine is the color of cola. Okay, so what's causing that? We know that we've already got probably red blood cells or some sort of myoglobin spilling into the urine. Urine analysis reveals hematuria. Okay, so already what's damaged? Think about it. The glomerulus has to be damaged to allow red blood cells to slip through. It also reveals acanthocytes and red blood cell CAS. Okay, red blood cells, again, staring us in the face. His face and eyes are puffy. Okay, so he's got edema, he's third spacing. What is the likely diagnosis with this child's history? So here are our options. A, abdominal trauma. Well, they don't talk about abdominal trauma, so that most likely not the case, but we can keep that in the back of our mind. B, antibiotic exposure. So they're getting at probably as some sort of a tubular necrosis caused by a toxin in the going through the kidney. Probably not. Don't give a good stem for that. Congenital bladder defect. No. Diarrheal disease. Most likely not. They're not even mentioning diarrhea in this stem. So E, streptococcal infection. So I would definitely say E. This is a great case for a post-strep glomerulonephritis. So we would want to find out in the patient's history if he had a previous history of strep throat, and that would really lead to our diagnosis. So let's see. E is the correct answer. A recent streptococcal infection is the most common cause of glomerulonephritis in children. About 60% of all glomerulonephritis in children have a better prognosis than adults. Okay, good. All right, number 4. A 44-year-old female complains of swelling of her face, eyes, and hands. Urinalysis shows moderate proteinuria and mild glucosuria. Okay, so she's spilling protein and she's spilling glucose. All right, microscopic findings include red blood cell casts, glandular casts, and oval fat bodies. Okay, so we're already thinking that this is some sort of probably nephrotic syndrome. She is spilling a moderate amount of protein. So even though we don't have a number yet, we should be suspecting some sort of glomerular damage because she's spilling protein. And since it's moderate, it is suggestive of a nephrotic type etiology. But this question is asking, what is the initial treatment? So we've got 5 options here. A, ACE inhibitor. B, K-exalate. C, cyclophosphamide. D, high protein diet. And E, sodium replacement. So of all those, I feel like the ACE inhibitor would be the most likely necessary medication for this patient, because what we have is a glomerular problem. We want to reduce pressure in the glomerulus, and the patient is having what they would call nephrotic syndrome. So high protein diet is exactly the opposite of what we want to do. The K-oxalate we don't need because we don't even have a potassium level on her. And sodium replacement is not going to help this patient. She's already third spacing some fluid. So let's see what the final answer is. A, nephrotic syndrome occurs when sodium excretion, this is interesting. Listen to this. Nephrotic syndrome occurs when sodium excretion exceeds 3.5 grams of protein per day. I think that's a typo. Nephrotic syndrome occurs when protein excretion exceeds 3.5 grams per day. That's what it should state. Patients present with widespread edema and proteinuria. The presence of oval fat bodies makes the diagnosis. So there you go. The PANCE wants you to know that nephrotic syndrome is paired with these oval fat bodies. First line treatment is an ACE inhibitor to reduce protein loss and corticosteroids to induce remission. Dietary protein and potassium should not be excessive. K-oxalate is used to reduce high potassium levels. Okay, so that's answer number 4. If you've got a nephrotic patient, you should start them on an ACE inhibitor. 5, a 65-year-old male presents to the emergency department with penile pain. He is circumcised and the foreskin is trapped behind the glands. So what is this? So if the foreskin is over the glands, it's called a phimosis. If the foreskin is trapped behind glands, it's called a paraphimosis. So this is already what we know to be a paraphimosis, but they're going to make us figure this out on our own. Okay, the area is red, swollen, and very tender. After manual compression for 5 minutes, the foreskin was released. What is most likely in the patient's history? So you've got this patient. He's uncircumcised and the foreskin is trapped behind the glands. So he's uncircumcised. So normally the foreskin's over the glands. What happened is it went back over the glands. Okay, so with this patient, we have a paraphimosis. So your options for answers are benign prostatic hypertrophy, maybe, but this question is not really leading us that way. Chronic balanitis, maybe, but they don't talk about balanitis, so that's a little bit less likely. Diabetes mellitus type 2, maybe if they were saying there was some sort of a fungal infection or even just an infection period, that would make us a little bit more, it would make us a little more suspicious of diabetes. Frequent catheterization. That definitely could be a cause of this, because when somebody is catheterized, this question is really making you think deeply. So when someone is catheterized, think about it. They retract the foreskin and then they cath them. Now, if you don't put the foreskin back, then the glands can swell up or the foreskin can swell up and it won't be able to go back over the glands. So that's why if we ever cath someone and they're uncircumcised, we want to make sure that we manually put the foreskin back over, because they'll get a paraphimosis. Multiple sex partners. So I think this is a pretty complicated question. There's a lot going on. Definitely a urology-based question, but if I had to put my money on it, I would say frequent catheterization. So let's see what they said. Number 5, D. So frequent catheterization. Entrapment of the foreskin behind the glands, paraphimosis, should be reduced urgently because prolonged obstruction may lead to tissue infarction. In other words, the glands can die. So that's not a good thing for this poor guy. Frequent catheterization without returning the foreskin to its proper place is a frequent cause. Sexual intercourse may also lead to a paraphimosis if the foreskin is left retracted too long. However, multiple partners does not change the risk. Chronic balanitis and diabetes type 2 predispose uncircumcised men to phimosis. So phimosis is stuck over the glands, paraphimosis is back. I think we're going to go over a little bit more GU later, but this is good to just kind of plant the seed. Okay, number 6. So a 12-year-old male presents with swelling and tenderness of the left testicle. 2 weeks ago, he had fever, loss of appetite, and tenderness and swelling under his ears, which resolved within 3 days. What is the recommended management? Okay, so what are they getting at with this? Okay, so let's read this again. A 12-year-old male presents with swelling and tenderness to the left testicle. Okay, so there's some sort of epididymitis or some sort of infectious process going on with the testicle. 2 weeks ago, he had fever, loss of appetite, and tenderness and swelling under his ears. So that's what the tonsillar or the submandibular lymph nodes. Resolved within 3 days. So he probably, they say bilateral. They just say under his ears. So he may have had an infectious process or a viral infection or some sort of like maybe mumps. Mumps is sometimes this precursor to epididymitis. So or orchitis, epididymitis and orchitis. So orchitis would be inflammation of the entire testicle. Epididymitis would just be inflammation of the epididymis. So let's see what the options are. So A is antibiotics. Oh, what is the recommended management? Okay, so A is antibiotics to cover gram-negative bacilli. Maybe, but I'm not convinced it's gram-negative. Fine needle aspirate of scrotal fluid. No, they don't even really talk about a lot of fluid. Ice and analgesia, probably if we're talking about orchitis. D, a testicular ultrasound to rule out mass. Now, in real practice, that would probably happen. Or E, referral to urology for further workup. So that is a really tough question. I'm going to go with ice and analgesia because I think what they're getting at is this is probably an orchitis, in which case it's going to be self-resolving. If I was in an emergent setting or in a primary care setting, I would definitely get my specialist on the phone to discuss this case with. So let's see what the review book says. C, so C was ice and analgesia. Orchitis is the most common cause of orchitis. Orchitis is the most common cause of orchitis. It's mumps is the most common cause of orchitis in prepubescent males. Treatment is ice and analgesics, such as acetaminophen. Bacterial orchitis occurs more commonly in older men and is treated the same as epididymitis. Okay, so in an older man, we would do the antibiotics to cover gram-negative bacilli. So this is why PANCE can be really difficult, because we need to know our populations, and we really need to dissect these questions because they're going to make you think at a very high level. So what else do they say? Treatment with ice and analgesics such as acetaminophen. Bacterial orchitis occurs more commonly in older men and is treated the same as epididymitis. If a testicular mass or torsion is suspected, ultrasonography and an urgent urology referral is recommended. So they're throwing a lot of stuff at you, and they're trying to make you remember what ages and how to treat. That's a tough question. Okay. 7. A 26-year-old male presents with fever and dull, achy pain in his scrotum, which radiates to the left flank. The epididymis is swollen and very tender. Urine dips reveal proteinuria and bacteriuria. What is likely in this patient's history? Okay, so he's 26, so he's young. Okay, so definitely STI is on my radar. Okay, he's got a fever, so he's a little bit toxic, and he's got pain in his scrotum. So it's probably some sort of orchitis or epididymitis caused by a sexually transmitted infection, mostly due to his age. Urine dips reveal proteinuria and bacteriuria. Okay, so bacteriuria in a clean catch male is a significant finding because it's normally sterile urine that a male is going to give us. Okay, not as big of a deal with a female because their vaginal tract is lined by bacteria. And so we will see that as normal in a female, but in a male, it's going to be something that we want to take a look at. So your choices for the patients, what is the most likely in the patient's history? So always make sure that you read through the question to see what are they actually asking. A high sugar diet, so they're getting at some sort of diabetic infection. No, I don't think so in this case. B, kicked in the groin yesterday. No, that would indicate a testicular torsion. I don't think that's what's going on. C, a new sex partner. I think we have a winner there. So let's see what else we got. D, recent diagnosis of diabetes. No, that really is ruled out by answer 1. And E, an uncircumcised penis. No, so none of these really make sense except the new sex partner. So let's see what the book says. 7. Number 7 is C. Epididymitis in a patient younger than 35 is most likely caused by a sexually transmitted infection, chlamydia or Neisseria. Diabetes may predispose males to chronic balanitis. Local trauma may result in torsion. An uncircumcised penis may risk for phimosis or paraphimosis. Okay, so sexually transmitted infection. Okay, number 8. A 54-year-old G5P500 female, 005 female, describes sudden urges to urinate. Often she cannot get to the bathroom quick enough and experiences incontinence. She describes fever, pain, hematuria. She denies, that's kind of a good word to make sure you read. She denies fever, pain, hematuria, or pyuria. Urinalysis is normal. Post-void analysis reveals minimal residual urine. The best management for this patient at this time is, okay, so she's had 5 kids and she's got 5 living children. We'll learn the G's and P's later. I don't think that's of high utility in this question. So what is the best management for this patient? So first of all, we know that she's probably having she's had so many children, so it's probably an urge incontinence. So that's where they're giving you that history. It's like she's 54, right? She's not pregnant right now, but she's had 5 kids. And that's something that's like, okay, they want you to know that she's had a bunch of kids. So that means something in this question. Okay, what is the best management? Okay, A, encourage frequent toileting to avoid a full bladder. She's already peeing a lot, so no. B, order urodynamic studies to assess the bladder wall contractions. You could. Let's see what else they got. C, perform bedside ultrasonography to rule out mass or foreign body. No, not high utility. And are we going to be the end all with an ultrasound of the bladder? No, that needs to go to urology. D, prescribes oxybutynin and reassess in 1 month. Yeah, I mean, I think if she's got urge incontinence, oxybutynin would help that. So that's a viable option. Let's see what E, recommend vaginal estrogen cream daily. No, this seems like a urge incontinence. So I would say D, prescribes prescribe oxybutynin and reassess in 1 month. So let's see what the book says. D. Okay. A sudden urge to urinate followed by incontinence describes urge incontinence, which is a result of bladder wall contractions that are not under the control of the brain. Urodynamic studies will confirm this, but are not essential. A trial of oxybutynin is warranted. If the symptoms are resolved, no need for further studies. Frequent toileting is recommended for overflow incontinence, which is caused by retention and bladder distension. Estrogen cream is recommended for women with stress incontinence caused by elasticity of the pelvic musculature, often secondary to pregnancies. Okay, so that kind of goes through each option and tells us when it would be indicated and why it's not particularly indicated in this case. Number 9. A 60-year-old male presents with painless hematuria. He has smoked 1 pack per day for over 40 years. He takes metformin for diabetes and an ACE inhibitors for hypertension. Cystoscopy and biopsy reveal a transitional cell carcinoma. What was the man's likely occupation? All right, so they're trying to correlate occupational exposure with increased risk of malignancy. So let's see what occupations they give us. A car engine repair, not that I know of. B, coal mining, yes, but not for bladder stuff. That would be more likely some sort of a pulmonary pathology, which we'll get to next module. C, glass blowing, no, not that I know of. D, quarry work, no. E, rubber industry. So the rubber industry is probably the most likely. So let's see what they say. E, risk factors for bladder cancer include cigarette smoking, which if they would have put that as an option, I would have gone with that first. Exposure to chemicals from rubber, dye, printing, and chemical industries. Exposure to cyclophosphamide and schistosomiasis. Quarry work and glass blowing carry a risk of silicosis. Okay, good to know. Coal mining has a risk for black lung. Car brake work exposes individuals to asbestos. Okay, so a lot of those are pulmonary. This is the one that says, hey, bladder is more likely with individuals that work with the rubber industry. All right, so that's why these review books are so nice, because we can't teach you everything, but you're going to need to know it for the PANCE, and you just have to do question after question after question, because each time you pick up these little nuances, and you always want to read even why the wrong answers would be right, because they give you a nice amount of material to help you out for future questions. A 58-year-old male underwent abdominal CT after successful treatment of diverticulitis. A heterogeneous renal mass measuring 2 centimeters by 2 centimeters was found incidentally. Further workup confirms a Fuhrman grade 2 renal cell carcinoma confined to the kidney. What is the recommended treatment? So I think we've talked about this. There's only one treatment for renal cell carcinoma, and that is nephrectomy. So let's see if we're right. So A is androgen ablation therapy. No. B is combination chemotherapy. No. C is radiation followed by resection. That one, the resection's in there, but I don't think that's the answer. D is radical nephrectomy. So we know that that's true. So don't dissuade yourself by thinking that you're going to do radiation and then resect it. If the answer is what you learned, then go with that. And then E is surgical excision and chemotherapy. So let's see what they say. D. So early stage localized renal cell carcinoma can be cured by radical nephrectomy or total nephrectomy. Adjunct radiation or chemotherapy has been shown to prolong survival. Chemotherapy and radiation are recommended for late-stage disease. Androgen ablation therapy has a role in prostate cancer. So radical nephrectomy for renal cell carcinoma or total nephrectomy. All right, number 11. A 33-year-old female presents with acute flank pain and hematuria. She has a history of passing kidney stone 4 months ago. So she passed a stone, and now she's got flank pain and bleeding. No further workup was done at that time. She has had 2 vaginal births without complication, drinks 3 cups of caffeinated coffee daily, smokes 3 cigarettes per day, denies alcohol abuse, and uses condoms for birth control. She is 5'5" in height and weighs 160 pounds. What is the most effective lifestyle change that should be recommended? So it's basically saying, like, here's this gal, she's got a stone. What is the most, what is the recommendation that's going to help her reduce those the most? Avoid caffeine, A. B, drink a glass of red wine daily. C, push fluids. D, stop smoking. And E, lose weight. So I want to know what PANCE wants on this one, because I mean, what I would humbly do is have her reduce her caffeine and push the fluids, but I'm thinking that it's going to be stop smoking. So let's see. C, push fluids. Okay, good. So we are on the right track. The most important element in prevention of recurrent kidney stones is hydration. Okay, good. I thought they were going to want her to stop smoking, and I was like, man, really? I didn't even know that. Okay, so good. It was hydration. According to the Kidney Stone Institute, an individual should be encouraged to drink enough water throughout the day that they must wake up during the night to urinate. Smoking, caffeine, and alcohol have no effect on kidney stone risk. Well, I would argue that indirectly caffeine is, because caffeine is going to make you urinate more, so you're going to lose more free fluid. So then you're going to have less water in the body. So indirectly caffeine does make you eliminate more fluid. So yes and no, but definitely increasing water intake is the correct answer. Last one. A 61-year-old male fell off a ladder. He denies unconsciousness or trauma to the head. He has bruises on the left shoulder and lower back and several fractures in his wrist. Surgery is scheduled for tomorrow. The nursing staff is concerned about some abnormal EKG findings. At first, the T wave appeared large and thin. Now the P waves are flat and the PR interval is prolonged and the QRS is widened. This guy's in deep doo-doo. So his rhythm strip is starting to widen out. Those are getting to get wider and wider, and he's going to flatline on us. What is the recommended management? A, calcium gluconate. B, K-oxalate. C, hypertonic saline. D, magnesium supplementation. Or E, sodium restriction. So although K-oxalate, we're getting this great idea, right, that this guy is about to go into ventricular fibrillation because the T waves are starting to, the QRS complex is starting to wide out. So we've got to do something, but it's not K-oxalate, even though we know that potassium is the culprit here. The potassium was released by the trauma because the cells were lysed. So potassium was released because it's intracellular. So that's what they're getting at. You know, he had this massive crush injury, so his potassium spiked. We need to give him calcium gluconate. Let me see. That's got to be the answer. Yeah. So here's a little bit better reason why. So calcium gluconate. Hyperkalemia with ECG change is a serious condition. Calcium gluconate should be given to antagonize the efforts of hyperkalemia on the heart. Meanwhile, identification of the cause and treatment to prevent potassium retention should be initiated. K-exalate may be used to reduce the potassium level. However, stabilization of cardiac function is necessary immediately, and that's why we give them calcium. Sodium and magnesium should be monitored, but are less likely the cause of the ECG changes. Okay, so that just had 12 questions on it. I want to give props to this book because I'm reading directly out of it, so I don't want to plagiarize it. But this is the book it's coming from, and it's from the nephrology section. I highly recommend this textbook because it is a great learning resource. I hope that helps you guys with kind of where we're headed, and will definitely help you for the test on Monday. So if you have any questions, be sure to let me know. Have a good one.